As we're teeing up our next speaker, part of the reason we do these collaboratives is not only to learn from what's happening in Kansas, but all the great stuff happening from across the country, right? And so that's, learning from other states. So we heard some from Massachusetts. We are going to now hear from the great Badger State of Wisconsin. And we were so honored last night to have our Kansas FQHCs doing food as medicine learn about the group visit model from Dr. Maggie Larson from the University of Wisconsin. And I thought it would be great for our broader group today to hear a little bit more about this fascinating model it's been around a while, but it's not widely used in Kansas at this time. And so she's going to give us a high-level view of how it's used in her healthcare system and share with us more. So please welcome Dr. Maggie Larson.
Thank you. Can you hear me okay? Everybody can hear me okay? All right. I actually am going to ask everyone to just stand up for just a minute because we're just over an hour in and sitting and we've eaten. So just a little bit of my background. I actually trained in Kansas City, Missouri, and did many of my rotations in eastern Kansas and rural areas. I'm from rural Minnesota. Grew up in a town of about 1,000 people or less. After medical school and residency, I returned back to a federally qualified health center in rural Minnesota, about 2 hours north of the Twin Cities. And I loved it, but just like already we've heard so much, there are challenges working in rural areas and small areas. Just for various reasons, I was able to return back to an academic setting, and I now am a family medicine educator with the Department of Family Medicine and Community Health in Madison. Our residency program has 4 clinics. I work in Verona, which if anyone uses the Epic electronic medical record is where Epic is based. So Verona has about 10,000 people. Epic has 10,000 employees. So the town is small. There are many, many, many folks there that are building these EMRs. We also have a rural health center in Belleville, which is about 35 minutes out of central Madison. One of our clinics is called Wingra Access Center, that it's a federally qualified health center with about 70% Spanish-speaking population and underinsured, and then a northeast clinic of Madison. The Department of Family Medicine is very large, but I'm here to talk about a method that maybe we can incorporate food as medicine and nutrition. I am presenting as far as from like a clinic and a physician standpoint, but using some of my experiences to help you think a little different way of how we can include this. So you can sit if you want to now, or you can keep standing. I really don't mind. I have an ambitious slide set, so I'll do my best to not talk too fast and not read all the words, okay? And which one is it?
Didn't we have this problem last time? Okay.
Oh, I just need to point it in a different direction. Absolutely.
No,
okay. So really kind of the main take-home point is that I am presenting a model that I think can be very helpful as far as clinicians and as far as really affecting change. But what we are presenting, and even when we think about food as medicine, it doesn't necessarily change the communities in which we are serving folks and treating folks. It doesn't change policy or advocacy. And so that's part of the big goal, is thinking about we make steady progress in little areas, and hopefully then people can see this and actually like study this and evaluate this and make change. I also have the privilege of, I spend each week 1 day in what we call our pediatric fitness clinic. So these are kids ages 3 to 20-ish that already are faced with metabolic difficulties, chronic health conditions like prediabetes, hypertension, and weight issues. So I'm able to see as a family medicine doctor, and then within this clinical setting, how nutrition can play a really big role and make a big difference. So what are the components of a good life? That's a very sort of generic question, but I think it goes along a little bit with what we call, what used to be the triple aim, and now really thinking about like burnout and changes in the healthcare system, the quadruple aim. So we want to make a change to improve population health, really patient outcomes and patient-centered care, reduce costs for all of us, whether it's for patients or the healthcare system, and then improve the work life of healthcare workers. So I'm going to present a little bit of background data and then talk a little bit about food as medicine and how we have used group visits to hopefully make some difference in these aims or improvements. So the statistics are not great. We know as far as thinking about chronic health conditions, diabetes, hypertension, heart failure, and then the underlying kind of mental mental health and behavioral health issues that go along with that are profound. So what's also really challenging is so many of those in the United States have a chronic medical condition that because they don't have access to care or haven't been seen in a clinic, they don't even know. So the costs are profound. So we're really looking at what are the things we can do to help reduce costs, again, for patients and for the healthcare system as a whole. When we think about blood pressure, that has like the even greater effect than even diabetes alone. So almost 50% of adults have high blood pressure, and half of those are actually uncontrolled, or 25%, like I said, do not manage that condition well. So as a clinician, that means that I might see that patient like every couple weeks or every month for months to help manage their health conditions. We're adjusting medications, potentially need lab, and just thinking about disrupting their daily flow as well too, as far as getting out of work. We're able to maybe have them check at home and get their data into our system or use virtual visits to help reduce that. But it's pretty significant, and it takes a lot on all of us. So even just hypertension alone costs the US about $131 billion annually. Heart failure, that's $30.7 billion. So we know that in the healthcare system, right, we've already talked about the SDOH, and we screen all of our folks for SDOH, for sure at least annually. Every single visit, every kid is screened, every pregnant woman is screened, and I do obstetrics, so this is something that we continue to do and address. Oops, I'm gonna go back a little bit. But really, as far as health and healthcare, right, that's like 20% of actually what affects patient care and healthcare, or not healthcare, but patient health. So we have a lot of different places where we need to make a bigger impact. And when I decided I wanted to be a physician, of course, the big picture kind of thing is I want to help people. I was the one of my 3 other siblings who always was taking care of people and wanted to make people well. And I grew up in a rural setting and saw how impactful that could be. But wanting to help people doesn't necessarily address actually like the economic stability, education, social and community, all of those things that really build that safe environment that really create health. So I have a small impact on that, but I'm optimistically wanting to create a greater impact on my communities, my state, and then even nationally. We know that with COVID, the disparities in SDOH have markedly changed, right? And I have 3 children, and I gratefully had a husband who was able to stay home with my 3 children. In Madison, the kids literally were home for an entire year doing virtual schooling. This was really challenging, and I am a physician. I came from we have a dual income household. It was very difficult for us to, mental health, physical health, just safety, even knowing what to do. When I had to go into the hospital and potentially be exposed to COVID, trying to decide, can I come back to my family and be safe as well too? But really thinking about healthcare risks and changes, and even more so than food security was greatly affected. And so we know that food insecurity has been rising, but COVID disproportionately affected those who already had some of those disparities. So when we're thinking about use of food pantries or food banks, this is significantly more. And those who are part of families, so in kid households, that's even greater than the general population too. So where can we make a difference? Feel a little sad, like how do I move forward? So thinking too about what the standard American diet, also called SAD diet, provides, the statistics are a little bit sad. And I presented this last night when we talked a little bit about nutrition in our Food is Medicine and group visit workshop. But right now, what currently is happening are 1/3 of US folks are obese. 60% even of middle schools and high schools have soft drinks and soda. We spend a large amount of our money on fast food, processed food. About 70% of the food that is available in the United States is ultra-processed food, right? So those that have been stripped of the benefits and the fiber and the vitamins, but it's cheap, it's available, it's at the end of every single grocery store, easy to find, and it's what most of us see all the time. Now, this is just a reminder of that in addition to kind of changing social determinants of health as well as the increase in chronic medical conditions, I sometimes, after a long day, especially on Friday, I've been in clinic all week, my husband's like, what should we do tonight? And I'm like, nothing. Absolutely nothing. I talked to people all day. It was so cold. In Madison, we got 20 inches of snow a week and a half ago, and then subsequently had like 10 below temperatures for the whole week. So, some of us choose to isolate, but in fact, social isolation has now also really, we found, and even worse since COVID, started to be a new health problem, right? We can see statistically that those who are isolated, whether it be geographically or socially, have a much higher risk of healthcare complications. Can we prescribe friends? That's really hard. We can't. But more than anything, when people come in for their annual visit, which now in my clinic, is 25 minutes, and I'm going to do your pap smear and do your breast exam and talk about your diabetes and talk about your mental health, and we're going to look at that skin spot, and we're going to flush out your ears. They need someone to talk to. And that is something I had a little bit of training with because I was a psychology major, but that's not necessarily what the best use of my time is necessarily at that time too. So what can we do to make a difference when we're thinking about the changes in SDOH, the food changes, and thinking about what has happened as a healthcare provider and with clinics is that many people are just done. They're just exhausted in any ways. So what can we do to make a difference? And that's what I want to talk a little bit about today. So underlying almost all of these elements, whether we think about social isolation, chronic health diseases, as well as those social determinants of health, but access to nutrition food is really critical, and not just to health, but thinking about resilience and really reducing that isolation. We know that food insecurity is independently associated with every chronic health condition that there is. And the amount of money spent related to those conditions is profound. So the food is medicine pyramid that we saw earlier, and this is actually extrapolated from the state of Massachusetts, really talks about ways that we can start with both prevention and then treatment. And I think, right now we're kind of in the middle there, right? Like we definitely would love to improve school foods. We'd love to be able to expand and provide more benefits from WIC and SNAP, but that's a hard thing to have a lot of buy-in. And when states, independently can choose how to do that rather than nationally, it can be challenging as well too. We also, again, wanting to switch and kind of move that spectrum of what America currently eats to what we can eat, that whole foods and plant-based eating plan that really is the basis of food as medicine can make a huge difference. So where do we start? And that's where a group visit program are really thinking about the different parts of moving, nourishing, behavioral modification, social support, emotional help. We have found that some benefits of group visits will hit all of that. All right, I think so. What is a group visit? Some of us might have heard of this as a shared medical visit or a group visit. And essentially is exactly that. We're gathering a group of patients together in one physical location. You are being observed by others, and that actually is a benefit to both. Patients can see how I, as a clinician or my behaviorist or my dietitian, interacts with those patients, and then patients are learning from each other. And then I am observing how my patients also are interacting, giving me feedback on what works best for them. So as a clinician, as I just described, we are so constrained by time, lack of incentive. There's really not a whole lot of, we are paid by our visits, right? We are not necessarily universally paid on quality. And that's starting to shift a lot in the state of Wisconsin by like blood pressure control and diabetes control. But underlying the overall healthcare system often is an RVU reimbursement model, so number of visits and kind of complexity of visits. But oftentimes in that one-on-one visit, both myself and my patients have very little momentum. Talking to a few clinicians commonly is, you see a patient for diabetes, we talk about medicine changes, we talk about exercise, we talk about eating differently. They follow up in 3 months and, guess what? Someone got sick. The car broke down. I forgot what I wrote down, and so there's not a whole lot of movement. So I can repeat this message 15 times a day, or how about if all of those people come together and we talk about it together, and we talk about how we as a group can collectively do that. What's fantastic too is then we can get all of our ancillary staff that are so experts in those areas, our dietitian, our behavioral health therapist, even like a physical therapist, a clinical pharmacist, and social worker in one place to provide their expertise in those similar messages in one place. So how does it work? Again, more time. Group visits typically would be like 90 to 120 minutes. You're able to talk a lot more in depth about different topics. When I first came to the department, they already had been doing group visits on diabetes management and tobacco cessation, and that could be expanded to many different chronic medical conditions as well. So this really isn't a substitute, but more sort of an adjunct or as a way to provide different and more in-depth care. And more than anything, oftentimes we as individuals think that I am the only one who's going through this, right? I can't believe no one else. I can't talk to my friend about how hard it was to make food last night. I have 3 kids, not a single one of them likes the same vegetable or fruit. How do we manage that at all too? Or if I get home at 6 o'clock and then we're supposed to go run to like the church confirmation meeting at 6:30 or a sports practice, like how do you manage that in like real life and busy lives? So really interactive activity and that time to provide comfort and truly friendship are huge benefits of group visits. What do? We can actually talk with our patients and find out in more time what were the barriers to actually having success in their chronic health conditions. We're able to more effectively teach self-management tools. So instead of just us saying, do this, they can say, hey, I think I can do this. This is how I manage my blood sugars when I'm really sick, or this is how I manage my blood sugars when I can't eat all day. We also can do that in a manner that's culturally appropriate. So depending on where you work, perhaps having your clinicians that are Spanish speakers or involving an interpreter in one place for all of those services rather than an interpreter coming in for 15 different visits. It's just in one single place. And really, I think oftentimes our underlying theme in those group visits is, perfect is the enemy of good, right? How many times have we seen that? And I think all of us probably are here by trade because we are so wanting to be perfect and make it better, better, better. But actually, you don't have to be perfect to be successful. Just forward progress, or at least not falling back in progress, still means success. Insurance reimbursement and getting paid. So this is kind of as far as the logistics. I don't know how many people say, there's no way that works. We haven't been paid for group visits. We aren't able to bill that type of component. If you have a clinician, whether that's a PA or a physician or a PhD, perhaps providing mental health services, if they're able to have very brief, even like a matter of a couple of minutes of one-on-one time with patients, and that again, that can be in small groups, you can bill an E&M or a level of service code. And that's often what helps to drive the financial and reduce overall costs. You can also, depending on the services, potentially bill educational time, but that can be really tricky. And we'll look a little bit of kind of our time slots when we do group visits, that as a clinician providing the education, I'm probably not meeting the time enough to be able to bill for that. Again, patients are semi-private, so each of them are roomed individually. Roomed, we call it, like taking vital signs, weight, reviewing medications and pain, as well as any changes in mental health. But really the point is they're not undressing, we're not looking at that funny skin spot in their back. Those would be addressed at a separate visit. And then thinking too about scheduling, a group visit requires a large space, not as big as this beautiful space there is, but an area that can accommodate a larger group. And we try to schedule these visits so it's kind of the tail end of clinic. We can still use our reception staff. We usually try to do about 2 MAs to be able to do all of the rooming for the clinics. And then we're not able to have, no one has to stay late, you might say. And then after visit summaries are things we actually can print, from the room or mail to patients too. So thinking about overhead cost, there really is none compared to your standard clinic visit or standard visit time. So the whys, why we would do this. And we've seen a little bit of data even with why we use food as medicine. So when I came to the department and prompting my move from rural Minnesota, I think to the department and wanting to be part of education was this. I had 3 small children, one with significant health conditions. I was far away from my family, even though that's where I grew up, but at least 2.5 hours from my family. And I was like, I am so tired. I don't have any money. Relatively, right? Like thinking about the costs that children and families do. My back is hurting. how do I make myself happier? And what do I do to actually be able to continue to be joyful when I see my patients? So the whys really go along with what are the benefits of group visits. When we think about overall, when we look at time, significantly reduced healthcare expenses. And that happens to go along with, particularly when we see people with blood pressure, diabetes, heart failure, as well as with centering pregnancy groups, reduced hospital admissions, fewer visits to the emergency department and subspecialists. Because we try to maximize on immunizations during visits, higher immunization rates and patients being able to come in. Those using centering pregnancy and our local insurers are now providing doula services. We know that will reduce rates of preterm birth and low birth weight babies, as well as initiation of breastfeeding, although we haven't necessarily seen long-term continuation of breastfeeding. Improve self-efficacy, improve physical function and quality of life in many people who have pain or diabetes, healthy behaviors. Looking at the metrics, yes, we can see a statistically different and significant reduction in A1C, parts of our cholesterol, blood pressures. Sometimes too, I think of, we started and did a lot with weight management, but what we call the non-scale victories. So fewer medications. Their knees are hurting less. I went down on my CPAP settings. All of those things play a big role that aren't necessarily as measurable as the numbers. And also thinking patients were happier. I came home from work a lot happier, and my medical assistant said, this is so cool. So really thinking about, again, beyond even just the financial benefits, that there really was a lot of benefit. It made me much more excited to be able to help take care of my patients with diabetes and blood pressure. It made me feel like I was making a real difference. So this is kind of an idea that stemmed out of one of our clinicians that is part of our group visits, Dr. Brian Arndt, one of my good friends and colleagues. Wisconsin does not have a Medicaid grant to cover nutrition services, but food is medicine is definitely spreading widely. But really understanding that we as clinicians and as a healthcare site are just a marginal piece of the picture. So this all began when I first came to the Department of Family Medicine. We started to transition from just the Department of Family Medicine to community health. So each of the resident clinics were asked to really look at the communities in which they served and say, what can we do? And we found, just looking at CDC data at the time, as well as what's called Healthy People 2020, which is now a little bit old, and then using kind of EPIC data, pulling from the chart, that a large population, even despite diabetes for us, is no longer at 4% of our population. It's more like 10 to 12%. But that the biggest code that we were seeing was actually obesity, or a BMI greater than 30. And we said, let's target kind of weight and those medical conditions that are going around it to see where we can start and change group visits in our clinic. So this is our current team. I'm obviously just one person there. 3 at the top are our faculty members, and then we have 2 resident physicians. In my clinic, we have 12 faculty physicians and 12 resident physicians, essentially at any given time. That's a lot of bodies for a very, very small clinic in a town of 10,000 people. Now, over the last few years, we note that the U.S. Preventative Services Task Force, as well as the American Academy of Family Practice and the American Academy of Pediatrics, recommend that we offer or refer adults with a BMI greater than 30 or kids who have a BMI greater than the 90th percentile to intensive multi-component behavioral interventions, or 26 visits a year. So, how many people can do 26 visits a year individually with patients who have chronic medical conditions? Absolutely no one. There's just no way. And that's where sometimes those different components of a team can make a big difference. So we looked at, we asked ourselves, we kind of went out to the community and we said, who can be part of our group visit? Who can be part of this team model? We claimed ourselves as the hosts because we had the largest community room in the area. We felt for nutrition that at that time, UW has many nutritionists and dietitians, but none on site. So we consulted with community dietitians. We also had a needs network or a food pantry that serves about 80,000 people a year within our county, or about 10% of Dane County uses services there. For exercise or movement, we found a local yoga instructor, several local gyms, and personal trainers. We invested in a clinic behaviorist to be part of our sessions. And then we went to our insurance companies and said, we need some support. And I recognize that there's different payment models. In Wisconsin, there's 3 big insurers that even those big insurers have Medicare and Medicaid plans. And this allowed us, though, some kind of personal touch and connection to offer some coverage. For nutrition, like I said, we looked at Hy-Vee, and Hy-Vee is here in Topeka as well too. But there are dietitians at Hy-Vee's. Did you know that? Free services, drop-in sessions, dietitians that actually have free A1C days, free grocery tours, that actually have at least one, and then you can bill your commercial insurance if so desired for individual sessions. So within our group visits, we took some field trips. We did a grocery tour. We tried out the cafe at Hy-Vee. We also had several local grocers that just calling them up said, yeah, I want to be involved. And they said, I can't give a forever discount, but I can give a little discount, or we can give a little reduction in cost of produce. And in our 6-month program, Hy-Vee, for all of our patients, we're able to offer a 10% grocery discount on all items, excluding alcohol, tobacco, and pharmacy. We also said exercise, right? Movement. We can teach people how to move, but allowing them opportunities to move at a reduced cost could be a benefit too. We just called people up. We said, hey, would you like to partner with us? Do you think that it would be helpful, if you came to one of these visits and taught people how to move a little bit? Anytime Fitness said, yeah, absolutely. And then this year, Princeton Club, which is the larger exercise group in the greater Madison area, said, you know what, we'll cover all of the people for 6 months for free and provide individual sessions. I am a natural introvert as well, too. So this was uncomfortable for many of us to call these folks up, but that's what we did. And not a single person said no when he asked if they could help. And then again, the community partners with insurance sponsorship was a huge role in this too. So what did we set up? We set up a 20-week program. And this initially, like I said, 2014 was our planning stage. We had groups in 2015, all the way through 2020 until COVID kind of shut those down and moved them to hybrid. And then we restarted again last year, and now we've kind of restarted for this year as well too. This is a 20-week program. We have monthly in-person visits with options for virtual check-ins in between. People are recruited based upon their EMR data, what their diagnoses were. Although there's 3 of us that kind of run the group visits, every one of our clinic faculty and physicians was given a list of patients that met these disease processes and said, why don't you ask or see which one of these patients you think would be good for group visits? Maybe they're a high user of the medical system. Maybe we're really struggling, like you're not meeting progress. Each of our visits then start with about 10 minutes of vital signs and check-in, review of medications. We move into a guided relaxation or physical activity. We have asked many of our different local restaurants to see if they would provide a healthy meal, that it's a plant-based meal. We eat that together, often incorporating foods that people maybe are less comfortable with. I was telling our group last night that last week we had our first meal and group visit of togetherness, and we had a salad with lentil meatballs and eggs and corn and tomatoes and different types of greens and beans, and then several different whole grains. And everyone tried the meatball and we're like, oh, that's kind of a different meatball. And we're like, yeah, it's lentils. They're like, oh, amazing. And I took that leftovers home to my husband, and he was like, these are so good, and had no idea that they were lentil-based. But just trying different things to get people to try out new foods. And during that meal time, then we talk about an educational topic. And we as clinicians led some of them, but then we actually asked our behaviorists to come in to talk about goal setting and overcoming barriers. We had our physical therapist come and talk about movement and exercise. We had our dietitian come in and talk about specific nutrient changes or nutrition changes that might be most helpful for that medical disease. And then really the main part is a slightly smaller group goal setting. And we use the SMART goal format as ways to set specific goals that then we follow up in the interim and at our next group change as far as assessment and change. Then we offered emails with weekly nutrition support, with recipes, grocery lists, and kind of move forward from there. So what did we find? So after a few years of studying this, we found that, again, we had improvements in BMI, blood pressure, cholesterol, A1C. Although that doesn't look like much, we saw statistically significant weight changes, and that's about on par with diabetes prevention programs as well too. We also, surprisingly, we found significant improvements in mood. And when I think about that social isolation piece and depression or mental health being huge components to actually making a difference and change in health conditions, that was huge. And then we used the SF36 as an assessment tool to look at quality of life. And interestingly, again, too, we saw that most improved were actually emotional well-being and pain had huge improvements in the six-month session. And then we had our own assessment screens that looked at like vegetable intake and meal planning and activity, and saw a lot of improvement with that as well too. We were also then able to do a qualitative analysis, and if you have a cohort of like 15 to 20 people, that's not a lot of like big N data or numbers to really be able to study very well. So this was probably the most important for us. What we saw is that our patients universally were raving about how helpful it was for them. And then all of us as clinicians were like, this is really what makes me tick. I've learned so much about how to take care of people with diabetes so much better. I've learned so much of how to change my 3.5 minutes I am able to within that visit to say, this actually can make a difference for moving or for your blood pressure, or this can be a huge help for your sleep. And really the patients emphasize that those areas of strength were that whole health focus and that peer sharing and support. So new this year is Quartz has been able to actually, this year our cohort of patients includes, again, that local insurance company, Quartz, that has Medicare, Medicaid, and HMO providers. They are providing for each of our group members medically tailored meals. They're providing for each of the group members. This is actually for all folks in our groups, that produce passport or discount as well. And then we actually have what's called a little scan, a QR code that patients can bring to any of different 4 to 5 organizations to have a reduction in the cost of healthy meal choices. And this is just one other thing that when they're out in the real world, how to constantly have that reminder of making good choices. And then again, like I talked about, Princeton Club and local pools are offering discounts for folks. But really the group topics that you can include, this year our specific focus is diabetes. In the past it's been weight management, pregnancy-related changes, but it's boundless. On the right are our current group visit offerings for UW as a whole that are independent of our department. So these are just a couple of examples of other group visits that we've done. Again, thinking about, I mentioned the food pantry that we have in Verona that serves about 80,000 folks a year. We sometimes forget that actually our senior citizens are at the highest risk of isolation and food insecurity. Often they're cooking just for themselves. Financially they may not be able to afford things quite as well. So we asked those in the community, so not just patients of our clinic, to come in, and we learned how to cook together. And I know another doc, also like he said, he found interest in culinary medicine. This was a way for them to learn to cook and prepare things very simply that were healthy for them, and then have access to the food pantry as well too immediately afterwards. And many of those end up being folks that, despite their food insecurity, are volunteering at the food pantry. So again, another method to kind of use our community both to serve and ask for them to give back as well too. Cooking for kids is a huge part too. As again, the mom of 3 kids, I also got to be engaged in shop cooking classes for kids too, as ways for them to try new foods and meals and encourage whole families to be able to eat healthfully as well too. So really also too, thinking about being an educator for us has been a huge benefit for our residents and for our medical assistants to see a totally different model in how things work. We also train, we have MAs that go through an apprenticeship through our clinic. We have lab technicians. We have dietetic interns and pharmacy trainees in our clinic for them to be able to be part of this and understand and see how a group visit model can really affect change has been really, really fun. We are hoping to buy a new clinic, or not buy, but build a new clinic as well too. I was promised when I came there 10 years ago that it would be built in the next couple of years. But what we have learned from this program too is we can make a difference in the space we have. We now have a community garden. We now have been able to have a full-time, a dietitian, or as well as a diabetes education registered diabetic educator on staff to help, so it further reduces barriers for our patients to have access to that education. We now have a much bigger common space to have meetings. We've been able to bring physical therapy on site to help with our patients instead of, again, sending folks out to be treated or have guidance and exercise. That was another barrier to care. We now compost, and then really it's helped us to continue to ask more, to ask courts to give more, to ask insurance companies to give more, and to ask UW to give more to us so that we can better help with our patients as well too. So that's a lot of stuff, and I'm sorry it was very fast, and I definitely went over my time, but I want to make sure if you have specific questions, like I said, I'm not here as like that Medicaid waiver person information or kind of reaching out, but more of thinking globally, how can we use group visits in all of your services to make a real difference too and hit that quadruple aim?
And I saw a lot of people taking photos of the slides. With Dr. Larson's permission, we'll be sharing the PDF of these on our website as we do, because you had great slides, lots of information. We're shifting things around a little bit, so we're going to be going to break pretty soon, but we do have a few minutes if there are any questions after this jam-packed presentation.
That must mean that either you're asleep or you got what you needed.
I think wheels are turning. So I'm going to ask a question that was kind of discussed last night, and I think probably a lot of you might be thinking this as the really important CBOs in the room. So you guys as physicians called the CBOs or businesses and said, hey, will you help? And they said, sure. So it's like, yeah, this is a match made in heaven. But how would a CBO go about approaching a healthcare clinic and saying, we've got services, have you thought about doing group visits? I mean, how does the conversation go that way?
Yeah.
I'm sorry, community-based organization, or as Kim said, social service organization. Nonprofits doing really good stuff for people.
Yeah, so I will say that actually some of the connections, specifically like our local large gym, Princeton Club, happened to be a conversation had with one of our physicians with his patient in clinic. You know, he was commenting on that it's really hard, you know, to get to exercise. It's so expensive. And this patient said, you know, I'm the manager at Princeton Club. This sounds like something that I can make happen. So that isn't exactly that CBO coming in, but it's a matter of connections and communications. And then that person reached out to our clinic to say, let's affect and make change and develop a partnership. Now, we started this process 10 years ago, and like I talked about last night, is the first couple years were so hard, right? Like these small businesses every year, that Anytime Fitness, the clinic, the manager changed, you know, or like Miller and Son said, you know, we've had a really hard year because they're the local grocery. We can't provide any incentive. And so then we reach out and we kind of do different things. We still support Miller's and say, hey, guess where in Miller's you can find the healthiest produce or like the cheapest, you know, best package pasta, hoping that we still can work as a community together to find those things. But we're gonna keep looking to see if there's other outlets to have that community support as well too. What we found is that not necessarily those community organizations are required. Really, the group visit model without community support can still run and move forward. But thinking that nutrition is often the basis for improvement in so many aspects of health and resilience, like by having those extra helpers, it really helps for us to feel like we're not alone, and then really helps the patients to feel like my whole community is invested in me. I don't want to let them down either. They're providing this.
And you've got a question on Zoom that Gabby will read.
Oh, hey.
So we do have 2 questions from the Zoom chat, actually. The first one is, can you elaborate on the times that these were scheduled? Although it did not increase overhead, did it require certain staff to be available outside quote-unquote regular hours?
So that is actually the planning process. So if you want to start a group visit, planning exactly when and where and who will be involved is crucial to be successful. So we have had different time frames. We chose a 5 o'clock to 6:30 time frame for the first few years, and this year we switched to 4:30 to 6 o'clock. And the reason is because then the actual check-in and rooming process, we still have a reception staff and we have our MAs who are what we consider the closers of clinic are doing that rooming part. When that part is completed, they leave, the clinic is closed, normal office hours just like it would. Since COVID, we are no longer allowed to have our doors open any later than 15 minutes after closing time, and that's prompted the switch to the 4:30 to 6 o'clock part too. If that kind of makes sense.
Yeah, thank you.
Yeah, so there's also different models of group visits, though. There's what we call drop-in group visits, and this is fairly commonly used with centering pregnancy models. So one of our clinics, centering pregnancy, are models where people come in as a group for their prenatal visits. We try to generally group people in gestational age, maybe first, second, or third trimester, and then postpartum. But the thought is that there's an open time frame of 2 hours where anybody who is pregnant can come in during that time frame to be seen. And that's best, they found, based upon the busing and transportation schedule, that midday worked the best for those folks. If you're targeting maybe a group of those who are senior citizens or not working, especially for advanced care planning or chronic disease, then sometimes a midday might also be an option, and that uses kind of the lunch turnover time period to be able to use that time, and your clinic staff is on site.
Okay, next Zoom question. I would love to know if you're looking at the role of the gut microbiome in any of this work. More in the weeds, but thinking of how the type of foods impact behavioral and physical health beyond just food access.
Yes, and yes, and yes. So last night, just briefly, I talked a little bit about our educational topics that we cover in our group visits, and really thinking about choosing a whole plant-based nutrition plan tends to have the greatest evidence at reducing inflammation, and not even just for blood pressure, diabetes, cholesterol, but really thinking about cancer reduction, pain reduction, and mental health as well too. So we completely try to focus on using those goals, but knowing that that's not always feasible. So sometimes we talk about good enough for forward progress, just because thinking about going from our typical nutrition or diet plan to what is perfect feels impossible. So baby steps.
So again, the presentation and the slides will be available on our website following this. I know I can see a lot of you, because this is not really something that's being done in this state a lot, right? So we're all thinking, So if there's no other questions at this time, please join me in thanking Dr. Larson.
Thanks for having me.
Thank you.